Hello and welcome everyone to the McFarland Clinic webinar, Protecting Your Vision as You Age. My name is Shelley Jakey and I'm the Marketing and Public Relations Director for McFarland Clinic. I'll be serving as your host and moderator for today's 60-minute webinar. Before I introduce our speakers and our healthcare experts today, I do have a couple of housekeeping items I want to share with you. Before that even, I'm going to share with you Dr. Lipsey and Dr. Morrow are going to be our guest speakers. I'll be introducing them in a moment. They are going to be covering the following topics in the next 60 minutes. Annual eye exams, eyewear and contact lenses, common eye problems, eyes and aging, cataracts, and glaucoma. And of course, we'll leave some time at the very end too for question and answer. Couple of housekeeping items before I introduce our speakers and healthcare experts. You will have an opportunity at the end of the presentation after both speakers to be able to share some question and answer. Actually, you can enter those at any point in time during the webinar. I'll be taking a look at those and then offering those up to our healthcare experts at the conclusion of their presentation. You can use the Q&A function at the bottom of your screen on the Zoom screen. We are recording today's webinar, and we will place this recording on our McFarland Clinic website along with the slide deck so that anyone can reference that. Those that registered for the event will receive a recording of it once it's available. And also, we will offer a survey to all of you that are participating in today's webinar to provide feedback on the actual presentation and also to share with us what other healthcare topics are you interested in learning more about. Well, our healthcare speakers today are Dr. Phaedra Lipsey and Dr. Nicole Morrow. They practice at our McFarland Clinic Eye Centers here in Ames, and they do have colleagues at our other McFarland Clinic Eye Centers in Boone, Carroll, Marshalltown, and Nevada. So we wanted to share with you the network of experts that we have in eye care at McFarland Clinic. Today's speakers joined McFarland Clinic as new colleagues actually last fall. Dr. Lipsey in Optometry joined us in August of last year, and Dr. Morrow in Ophthalmology in September. And they are our guest speakers and experts here today to share more with you on how you can protect your vision as you age. Dr. Lipsey, I'll invite you to turn on your camera. And welcome again to the clinic and welcome to the webinar. It's been a few months now that you've been with us. We're delighted to have you here to share your expertise. So I'll turn the program over to you.
All right, thank you, Shelley. Thank you everyone for joining us. I'm going to kind of start at the beginning with just what is an annual eye exam. So we also call this a comprehensive eye exam or a routine exam. And I like you to think about this as like preventive health. So similar to a physical, something that you can have done routinely to just check for issues, even if there are none. So it's an evaluation of vision, eye movements, ocular health, and more. There is a difference between eye exams and vision screenings. So we'll kind of briefly view through that. A vision screening is typically performed at a pediatrician or at a school. It really focuses on clarity of vision, so whether or not you're seeing 20/20. So focusing on blur, either done by kind of reading an eye chart to see if your vision is 20/20, or looking at kind of a reflection of the eye to see if there's any problems that are shown there. So that identifies people who need a full eye exam. And then that eye exam is performed by an optometrist or an ophthalmologist. Typically, we prefer dilated eye exams. So again, with new technology, it's really exciting that we have things that we are capable of doing. So there is the option of photography, but I would say standard of care for most practitioners is going to be a dilated eye exam. It really depends on your own eyes and vision, but that allows the eye care professional to look at both the front and back of the eye. We're evaluating more than just the vision, but that is a component. So whether vision is clear, any misalignment of the eyes, or other ocular health concerns. In pediatric patients, we also can do a few other testing, kind of checking color deficiencies, depth perception. Little kids don't know any better if there's anything bothering them with their vision. So that's an extra step that we can do in eye exams. Really, screenings are probably primary ways that kids get their eyes checked, but it's always reasonable to have kids' eyes checked in kind of kindergarten or first grade as a first eye exam, just to make sure that everything's how it's supposed to be and set them up for success with school. And everyone else can kind of do an annual eye exam or whatever the recommendation of your eye provider is. So that's the eye exam basics. So what can we talk about in an eye exam? So often I think the thing most people are most comfortable with or familiar with is reading glasses, and that's probably because they don't always require a prescription. So that's what we'll talk about first. Reading glasses are needed because around 40 years old, the eye starts to lose focusing power. We call this presbyopia. Basically, you'll notice that that near vision isn't clear anymore. You either have to hold things further away, make them bigger, things of that nature. So unfortunately, we don't have any way of stopping that. It's a normal aging change, and it pretty much happens to everyone. So a lot of times the first step is those over-the-counter reading glasses, which is why people are most familiar with them. But that doesn't work for everyone. So if you've tried that and it's not working, it might be time to come in for an eye exam and kind of see your other options. So beyond just the reading glasses, which don't need a prescription, there's also prescription eyewear. You may have seen a few of these terms before. Nearsightedness is also called myopia, and that when we say nearsighted, we mean up close is easier to see than far away. Vice versa for hyperopia, that farther stuff is easier than the up close. Astigmatism actually can affect both distances, and it has something to do with kind of the quality of vision. So that's also something we can write prescriptions for. We talked about that difficulty focusing. So if prescription readers don't work for you, it could be because each eye needs a different power or other reasons. So we can do prescription reading glasses. So you can have more than one of these conditions, which is why it's so personalized, and both your eye care professional and the opticians really can help you to understand your options in terms of glasses, whether you want to have far away and up close at the same time, other things of that nature. So it's a really personalized conversation with eyewear. And then I would say for those that don't want eyeglasses on all the time, we have the option of contact lenses. They really are for people of all ages. So I would say the earliest, we do have a lot of middle schoolers who start wearing contact lenses, as well as some really responsible elementary schoolers. So there's definitely no oldest age for contact lens wearers. It really can be any person. A lot of people were told maybe they're not a candidate for contact lenses. That's something that comes up a lot. But there's been kind of developments in that field as well. So there's a lot more people that are candidates now than ever before. So that can be a good option for those that don't want to wear glasses all the time. Maybe for the people who have not needed glasses and all of a sudden kind of that reading vision's getting harder. So that's something that we really like to evaluate in our patients. Moving on, kind of beyond just the vision, we also see a lot of eye problems. So we'll go through a few of the most common that come in, and starting off with dry eye. Some common symptoms are stinging, burning, grittiness, excessive watering. Your eyes can be red or irritated. Some people blink a lot more or feel like their vision's fluctuating. So it's clear sometimes, blurry sometimes, and it can be a bit frustrating. So this is really common, I'd say, in winter. So with temperature changes, humidity changes, and also for all of us on our digital devices a lot, we've seen people blink less on digital devices. So I think a lot of the workforce often comes in with complaints of dry eye. So it's definitely something that we take a look at, recommend over-the-counter options, prescription eye drops, in-office procedures. So definitely don't want people struggling with uncomfortable eyes. That's something we can take a look at. Next, we have styes. So these are changes to the eyelid. Sometimes it's painful and sometimes it's not. So this is a kind of a bump on that eyelid. You can get redness, swelling, tearing, crusting. We do really want to check on these if you feel like you're feeling some pain or if you're having vision changes, just to get the best treatment method for this size to help relieve those. Next, we have pink eye. I think a lot of people are probably familiar with pink eye. There are many causes, but typically when you're looking at your eye, it's going to be red. So you could feel like it was painful, like it was itchy, vision blurring, burning, light sensitivity, again, crusting on the eyelids and lashes. So again, pink eye, I mean, there's a lot of reasons an eye can be red. So we really want you to come schedule an appointment if you're having concerns to see if it's bacterial, viral, allergy, inflammation, and really get the best treatment. So I think a lot of people maybe are concerned when their eyes are red and do want to be seen, and we're definitely happy to see you at the eye clinics. And then a little bit less, or I guess going back to what we were talking about, the focusing problems, it goes beyond kind of that clarity of vision we were talking about. So even if things are clear, you can still have tired eyes. I think that's a really common complaint. So we're talking about kind of a strain around your eyes or your forehead by the end of the day, or just difficulty looking far away and then up and close, vice versa. So any of those things can have different reasons in terms of how the eyes are working together. So that's something we can evaluate if you're having difficulties. And then worsening night vision is also a pretty common complaint. So this can either be you feel like your vision is blurrier when it's dark out versus when it's light out, or that you're getting kind of more glare or halos around lights. So there's a few causes for that condition. So again, make your eye appointment. We'll kind of run through anything that could be causing any of those eye problems. So whether or not you need glasses, whether or not you're having any eye problems, kind of what are the basics of keeping eyes healthy? So we can touch on specifics a little bit later, but in general, nutrient-rich foods. So we want you to be getting your vitamins, your antioxidants, maybe omega-3 fatty acids. This is a little bit condition dependent, so I don't have necessarily a broad recommendation, but we do want just a healthy diet. Anything kind of for your overall well-being is going to be helpful for the eyes as well. One thing I want to talk about in particular is that UV protection. I think that sunglasses get missed a lot, but they're very important. So I did see someone asked about kind of sunlight, and yeah, we do find benefits from sunlight in life. So I mean, vitamin D, kind of regulation of the sleep cycle. We've found that kids that play outside more maybe won't be as nearsighted. So there's a lot of positives to sunlight, but we also know that there's multiple structures in the eye that are damaged by UV rays. So when you're looking for sunglasses, not all of them actually block that UV light. So you want to make sure they're certified to actually block nearly 100% of UV light. What else is screen time? Again, easier said than done to reduce screen time. I think we talk about this in a lot of pediatric or teenage exams, but it can be helpful to just do a little bit less work up close. We talked about how you can get kind of that dry eye feeling on devices, but also just that fatigue from looking at the same area for a long period of time. So either reducing screen time as much as possible or simply taking breaks. So every 20 to 30 minutes that you've been focused up close, try and relax the eyes by looking further away. And then lastly, the annual eye exam. So a lot of this is really personalized. We are happy to talk through issues in your daily life and your habits, your activities, your work. So getting that annual eye exam is there to address problems, but also to actually screen you for different eye conditions or diseases. So that's kind of this next portion we'll head into is what are certain eye conditions that we're watching you for when you come in for your annual eye exam.
Thank you, Dr. Lipsey, for sharing your expertise. Again, that was Dr. Lipsey, optometrist with McFarland Clinic Eye Centers. And next speaker and healthcare expert is Dr. Nicole Morrow, ophthalmologist with McFarland Clinic. And a reminder to everyone, we will do a Q&A session at the end. So feel free on the Q&A button at the bottom of your screen. If you want to type in a question now, I'll be looking for those. And as Dr. Morrow completes her presentation, we'll have both of them join us and we'll do some question and answer at that time. So welcome, Dr. Morrow, to the webinar.
Hello, thank you. Hi, everybody. Welcome to our talk today. I'm going to get a little bit more in depth about some eyes and aging issues and some medical conditions that we can see in our eyes. These are the topics that I will talk about. Presbyopia or the need for reading glasses. Dr. Lipsey already covered, so I won't go into much detail for that, but I will discuss cataracts, dermatolysis or extra eyelid skin, glaucoma, age-related macular degeneration, and diabetic retinopathy. For most of these, we recommend yearly dilated eye exams, so just kind of keep that in mind as we go forward. So we'll talk about cataracts. Everybody is born with a lens in your eye, and it is clear when you're born. As you get more birthdays, as we get older, it gets a little bit more cloudy. It looks yellow to me, but it's just more of the layers get added. Some of the symptoms that you will have as your cataracts progress is you can have blurred vision, decreased contrast sensitivity. You might have some distortion, significant glare or halos. Issues with nighttime driving are some of the most common symptoms that we see with cataracts. The onset is most common after the age of 60. However, lifestyle factors can really affect the onset and progression of cataracts. Sometimes it's younger in patients who have certain medical conditions. And as Dr. Lipsey said, sunglasses become important because UV exposure can also cause cataracts to progress more rapidly. If you smoke, use long-term steroids, or you have trauma to your eyes, these are other reasons that you might have a cataract sooner than your other people that you know in your life. Treatment for these, as the cataract continues to progress, sometimes we can just update your glasses because it can change your glasses prescription as the cataract progresses, and we can still get you to 20/20 and you see very, very well with your cataracts. There is a range when you have cataracts that we don't do surgery on. They're just there. They're not ready to come out yet. But ultimately, if it comes to the point where you do need surgery, the key is that on exam, they look like they're ready to come out, and you have factors that are affecting your activities of daily living. So we do the surgery when it's affecting your life and making sure that it is the best case for you to proceed for surgery. Dramatic chalasis, or extra eyelid skin, is we just get an excess or redundant skin. It can set on the top of your eyelashes. It can weigh down your eyelids. Some people feel like they have to really raise their eyebrows to be able to see. When that skin overhangs the eyelashes, you can get decreased peripheral vision. And then the tired, heavy eyes is because you're really, really trying to work to raise your eyes open. Risk factors most commonly is age. As we get older, the elasticity and collagen in our skin decreases and everything descends. And so that can cause this eyelid skin to descend. Also, family history and genetics. If your eyes are made a certain way, sometimes that is how it looks. I've seen a lot of family members who have similar eye shapes. A lot of them may need the same eye surgery. The treatment for this, when it becomes visually significant, is eyelid surgery. We can just excise that extra skin, and it helps kind of increase the peripheral vision and not weigh down your eyelids as much. So for glaucoma is a disease of your optic nerve. The optic nerve, as you can see in this picture, it's kind of that cable at the back of the eye. It's the cable that connects the brain to the eye, and we can see the end of it inside. And so when that optic nerve becomes more cupped, meaning it looks like a donut and that center part gets a little bit bigger, that might mean you've had some damage to that optic nerve. And the damage that causes is initially a peripheral vision loss. So symptoms for glaucoma, for a lot of patients, it's very asymptomatic, meaning you do not notice it because it is your peripheral vision. So that is why it's important to continue to have an eye doctor look at your optic nerves to make sure they look healthy and that you're not at risk for some of these peripheral vision field losses. Biggest risk factors for glaucoma is age. The older you get, the bigger the risk factor. If you have a family history of glaucoma, it's also important to get your optic nerve looked at. If you've ever been told you've had higher eye pressures, that's also a factor. And if you've had trauma to your eye, or sometimes people's eyes are made a little bit different. So where the normal drainage system is, it's not functioning correctly. So when we look at your eye to see if you need glaucoma, if you have glaucoma, we look at your optic nerve on exam. We can also get a scan of your optic nerve that looks at the different quadrants of the optic nerve to make sure that there's no thinning. We also can get something called a visual field test, and you push a button when you see a light, and so we can test all of your peripheral vision to see if there is any decreased peripheral vision. The initial treatment for glaucoma, that is usually eye drops, or sometimes you can do a laser in the angle of surgery to help kind of remodel your drainage system. So the medication or topical eye drops, they're very well tolerated. Sometimes people need multiple drops to have an eye pressure that is okay for their optic nerve. Some people need more advanced surgeries for their glaucoma when they get into the severe stage. Some people and some other people can have more mild glaucoma. So when we actually start talking about cataract surgery, I can put little stents in the angle of your eye. So sometimes some people can come off of eye drops after cataract surgery if we do cataract surgery, or if we do cataract surgery with these stents to help lower the eye pressure. So age-related macular degeneration is a disease of your retina. Your central retina is called your macula. That's where you get your high acuity 20/20 acuity vision. Basically, the cells in there don't function correctly, and you get a buildup of like waste products, and it causes damage to some of those retinal cells. When the damage happens in the early stages, a lot of people don't have any symptoms. But as it progresses, you might have some blurred central vision. You might have some distortion. And when I say distortion, it's when straight lines might be bent or curved. Sometimes people have missing spots. As macular degeneration progresses, the vision loss can be severe. A lot of risk factors for macular degeneration, but the two main ones are family history and smoking. So family history you can't modify, but decreasing smoking, avoiding smoke exposure, you can. Making sure you're also like blood pressure. They've seen associations with blood pressure, so making sure your blood pressure is really well managed as well. I think there's two types, dry and wet, which we'll go into in the next couple of slides. So this is just an overall schematic of basically dry and wet. So dry macular degeneration, there are 3 stages. There's early, intermediate, and severe. That center picture is what it looks like. Those kind of light, white, fluffy things that you see represent drusen, or the buildup of those waste products that are not being removed properly. And that is what causes damage to the retina. And then wet macular degeneration is where there's bleeding in the retina. There's new blood vessels that shouldn't be there. And then you have bleeding, and we treat that a little differently. So dry is the most common. 80% of people have dry. It's characterized by those drusen, which are those little deposits that were seen on the previous photo. We don't have any specific treatment for drusen. You guys might have heard of the AREDS 2 vitamins. These are eye vitamins that have a bunch of supplements in them that are known to support eye health. Depending on what type of macular degeneration you have, there's been some benefit shown to help slow the progression, specifically from the intermediate to the severe. So that's a conversation we can have if they're right for you or not. So one of the newer things that we've seen with dry macular degeneration, when you get to the severe or atrophic types, there are new intravitreal or injections that we can put inside of the eye that can help slow the progression of the atrophy that can come from advanced macular degeneration. Overall, stopping smoking, avoiding smoke exposure, having a healthy diet, just like Dr. Lipsey already said, and then we give you a grid to help you kind of monitor any changes. So wet macular degeneration is less common. When we get those blood vessels that form, the vision loss is usually much more rapid. So you would notice a rapid decrease. So if you do have macular degeneration, and you see a rapid decline in your vision, call your eye doctor, make sure they can come and see you, or you can come and see them. And treatment for this is, we still have our patients on the AREDS vitamins and, smoking cessation and all of the same recommendations for dry, but we put intravitreal injections on the list, and we have a variety of different ones that we use to help dry up the blood and help keep it from reforming. And some people do have some laser surgeries that we can specifically target some of the leaky areas. So diabetic retinopathy is damage that's done to your retina in patients who have diabetes. Diabetes affects the small blood vessels throughout your entire body. So people get, neuropathy in their toes and their fingers. They can have kidney problems, but you also have vessels in the back of your eyes. So it can affect the vessels and the oxygen that can come to your eyes. Symptoms, if you have diabetic retinopathy, might be blurred vision, due to if you have fluid in your retina. Some people with diabetic retinopathy can have that. You also might see fluctuating vision. When there are rapid fluctuations in your blood sugars, or your blood sugars run really high, it actually can change the shape of your cornea and your lens in your eye, which can change the refractive power of your eye. So it can make your vision blurry. Some people might notice some blank spots, distortion. In very severe diabetic retinopathy, there can be significant vision loss. The biggest thing with diabetic retinopathy is uncontrolled diabetes. So if you have diabetes and your A1C is below 7, you're in a safer spot. If your A1C is in the double digits, you're at a much higher risk for developing diabetic retinopathy. And since high blood pressure also can have an effect on your blood vessels, making sure if you have high blood pressure, it's better, it's well managed. And then genetics are always always play a little bit of factor in all of these diseases. This is a schematic. On the left is a normal eye, and then on the right we can see some of those round dilatations of the blood vessels are the changes in the vessels that we can see in diabetes when we look inside of your eye. And you can also see exudates where there's like the blood vessels are leaking from some of the new blood vessels that can form in more severe diabetic retinopathy. Treatment, we've talked about this, making sure you control your sugars, diet, exercise, high blood pressure management. Some people with diabetic retinopathy who have fluid or new blood vessels forming do get injections inside their eyes to help maintain the vision. Some people need laser in their retina, like all throughout the periphery or in particular spots. And sometimes people with diabetic retinopathy get bleeding in the back of their eye that's so severe that they need a retina surgery or a vitrectomy to remove the blood.
Well, thank you, Dr. Morrow, for sharing your expertise. And I would ask Dr. Lipsey to go ahead and turn her camera on. At this time, we're going to head into kind of the question and answer portion. Reminder, there's a Q&A button at the bottom of your screen. Feel free to type in questions. I'll be looking for those. We've had a few that have been submitted. And Dr. Morrow, I was just going to ask in terms of a lot of the surgical procedures that you were referencing throughout your presentation, those are procedures that you offer, correct, at the Eye Center?
Yes, I would say about 90% of all the procedures that I stated, we do offer at the Eye Center here, yes.
Okay, very good. Well, we'll start right in with some of the questions here. I see a couple of questions related to floaters in your eyes. What are they? What can you do about them? I'll just open up to either one of you to address that.
Sure thing. I definitely hear a lot of complaints of floaters. So in general, we do think that a handful of floaters are normal. So in the back of the eye, there's a vitreous substance, which is basically a gel. And that's inside that gel is where you get the floaters. So there's areas of condensation and they kind of cast shadows in your vision. So we do dilate eyes when you get new floaters. We always want to know if you have a lot of new floaters at one time, or if you're getting flashing lights, which I can describe as like a camera flash or lightning strike sensation. Those can be indicative of a change to the retina in the back. But in general, if you see a floater randomly kind of looking at the blue sky or a white screen, those are typically a normal change. Unfortunately, we really, most of the time, do not address floaters. So oftentimes people get this big floater around age 65 and it kind of just sits there. We do see kind of an adaptation to it where either your brain kind of stops paying attention and you don't notice it as much, or just isn't in your vision as often. But we don't have any eye drops. We don't have any medications. It's really just a surgical procedure, that vitrectomy that Dr. Morrow had mentioned. So we really have to evaluate kind of the risks and benefits of performing a surgery for floaters. I would say it's generally not something that we do, but we do want to see you for any new floaters or flashes of light.
I think a follow-up question that may be related to it. What about migraines? They last a few minutes with a flashing light. Is that something that someone might experience with floaters, and how concerning is that if someone has a headache associated with it?
Yeah, that's a really good question. So yes, you can have an aura before a migraine, or really even an ocular migraine, which doesn't have a headache. So always happy to evaluate those to, see which one it is. But generally speaking, we would assume that flashes or changes in your vision in terms of like colors or patterns, if those last under an hour, it's likely related to that headache. If they're lasting longer than that, we would want to dilate the eyes.
Okay, shifting gears a little bit here, are there any concerns with bluish, it says 5,000 Kelvin, I don't know, I'm not familiar with that, or higher LED lights, especially at night? So our exposure to really lighting indoors, let alone, I know you were addressing the UV protection we need to have when we're outside, but what about the bluish lights that we're exposed to? How does that impact our vision?
I'm not quite sure if I'm assuming they might be talking about like need for like the blue light blocking lenses or those really bright LED headlights that all the new cars have. For blue light blocking lenses, the data is very equivocal, meaning there's some data that shows that there's a benefit to patients, and then there's some that show that there's no difference. My recommendation would be just if they help you, great. If they don't, then it's okay. For those LED headlights at night, I am not aware of any specific damages that occur from them, besides that they're very uncomfortable to look at when we're driving. Some patients who have severe glare with nighttime driving that's not attributed to their cataracts or maybe dry eyes, they actually wear tinted glasses at night. Typically, a yellow tint can help really reduce that glare that patients have if it's not attributed to something other than their cataract or their dry eyes.
Okay. Another question here, is stigmatism and blurred vision related?
Yes, astigmatism can just be the cause of your blurry vision. It really is a complicated word to just mean that we're going to correct your vision in two different ways in glasses or contact lenses. So it has to do with the shape of the cornea, which is the front part of the eye. So if the cornea isn't perfectly round, you might need two powers to best correct vision, and that's what the astigmatism term is related to. So yes, you can just have blurry vision and have astigmatism.
Okay. Dr. Morrow, this is in regards to cataract surgery, and I know you perform cataract surgeries. Should eyelid or cataract surgery be done first?
It really depends. If you have both that need surgery, both eyelids and cataract surgery, I recommend cataract surgery first. Some people have eyelids that need to be taken care of many, many years before they need cataract surgery. So then we can do eyelid surgery first. But say if you have both, then I would recommend doing cataract surgery first and then proceeding with the eyelid surgery after you're healed up from your cataract surgery.
Another specific question, kind of following along here with the cataract surgery. This individual had cataract surgery, lens got cloudy, had laser surgery, caused blood in the front of my eye. How do I get rid of the blood? That's a very specific question, obviously, but I don't know if in terms of the outcome after cataract, if some things like that can occur with cloudiness.
Yeah, so there is about 20 to 25% of patients after cataract surgery will get a membrane over the back of that lens or scar tissue. Some eye doctors will say it's like the cataract comes back, and you do have similar symptoms that you had when you initially had your cataract. We treat that scar tissue on the back of the lens. We do a laser where we laser the scar tissue off of the back of the lens. If there is bleeding from that, usually the eye will reabsorb the blood over time. I think that if that's the question that they were asking for the bleeding part, but sometimes it can cause a little bit of inflammation, and that should also go away over time.
Does insurance cover eyelid surgery?
Yes, for certain cases, we do specific testing, and we always submit to your insurance for prior authorization. And once you meet certain peripheral vision requirements or where the eyelid sits in relation to your pupil, if you meet certain requirements, it's very dependent on your insurance, what they require. But then it can be covered by insurance, yes.
Okay. And just a reminder to folks that are listening in, if you have a question, you can certainly hit that Q&A button and submit. I'm watching those as they come in. We do have a few more. And again, appreciate Dr. Lipsey and Dr. Morrow's time here to help us work through some of these questions. Someone noticed that in the diagrams that were on the presentation, there was those yellow spots. I can't remember if that was with macular or diabetes, but they're asking if those yellow spots are actually cholesterol. What is that that's built up in the eye?
Go ahead, Dr. Lipsey.
Oh, okay, I was just going to say there was also the eyelid photo. I think those yellow spots were the potential from high cholesterol they were talking about. So it was actually on the skin. If you have really high cholesterol, potentially you could get yellow deposits on the skin. So correct for that one. Back of the eye is different. That part's not the cholesterol.
Okay. This question has to do with retinal detachment. Is there a way to prevent it? Is it genetic, or does it just occur randomly? So maybe a little definition of retinal detachment, what it is and what can you do to prevent it?
So I like to describe the retina like wallpaper. And a retinal detachment occurs when there is a tear in that wallpaper and the vitreous or fluid gets behind and it pulls away from the back of the eye. That's a retinal tear and retinal detachment. Um, Specific genetic risk factors, if you have a very like long eye, like your parents have a high prescription, like a high minus, like a -6, -10, that retina is a little bit more stretched, and so you're at an increased risk of a tear. When Dr. Lipsey was talking about floaters in the vitreous, that vitreous is firmly adherent to that retina, and so when you starts to liquefy as we get older and it pulls away from the retina, sometimes it can cause a tear. And so that is when we have those symptoms of flashing lights, because when that vitreous is tugging on the retina, it's exciting those retinal cells, and that's why you're getting the flashes of light. And so that's why we would like you to come in to be seen to make sure you don't have any tears. There's not a lot that you can specifically do to prevent it. People who do more intense sports like boxing, where you get a lot of impact to the eye, that might put you at a slightly higher risk. But for the average person, there's not really a lot you can do. Just monitor your symptoms and make sure you get a dilated eye exam to see if you have any peripheral retinal issues that might put you at a little bit higher risk.
Seems to be quite a few questions coming in related to eye vitamins. Just kind of like in general, we were talking about good health, right? But is there specific vitamins you'd recommend? And then questions specific to macular, someone who has a family history of macular, and they're asking for, vitamins. Maybe just kind of recap again, supplements or vitamins that could keep our eyes healthy.
So the AREDS 2 vitamins are indicated for certain people with macular degeneration. Not everybody needs them or there's a recommendation for them. All the really large macular degeneration studies showed that patients who have the intermediate stage, those who took the AREDS vitamins, had a slightly decreased rate of progression to severe. So that's where the benefit of those eye vitamins comes from. When they looked at the early to intermediate, there wasn't the same benefit. I think that it's very patient independent to make sure that you're not double down dosing if you're taking like a multivitamin and you're taking the eye vitamins. So that's why that's a conversation to see if they are indicated for you. If you have a family history, when you get your dilated eye exam by one of the eye providers, they will look at your macula, make sure your macula looks healthy, and if then there is concerns, then they can discuss that with you. Otherwise, just kind of making sure you get those green leafy vegetables, antioxidants, just like Dr. Lipsey had said, just to overall help your eye health.
Okay. If you have a black spot appears in our vision, what would cause that, a black spot?
Really depends. If it's constant, we would be a little bit more concerned of some kind of pathology. Hard to say which part of the eye, but so if it's always there, I would recommend being seen. If it's something that comes and goes, if you shift your vision to the left, then you see it. That could be a floater. They can be little black spots. They can be clear, kind of blurry spots. So it really depends on frequency of symptoms and kind of when you're noticing it.
Okay. Another specific question, can anything be done for a lazy eye in adults who have had it for many years? Maybe a definition of what lazy eye is, and is there anything that can be done?
So classically, when we think of a lazy eye, it's when we think of an eye that it turns in or turns out isn't looking straight. From our standpoint, when we think of that, that means that the eye vision may not have developed as well when the patient was younger. So that eye may have not as great as vision. There's no treatment to improve the vision as an adult if it didn't develop as it should, if that's what that person is asking. However, if the eye is turning in or turning out and they've had eye muscle surgery before, and some patients do need an additional eye muscle surgery, it's not always indicated to get eye muscle surgery as an adult, but some people do. If you want the eyes to, out, you can bring an eye muscle in. That could be something that could be done. But to actually improve the vision from having the lazy eye, there's no treatment for that.
Okay. Well, for the last 40 minutes, we've all been probably staring at a screen here. So this question is related to computers and using screens and its impact on your eyes. Does using a large screen computer cause more damage than using a smaller screen is the question. But I maybe just also have you speak to our use of screens in general and its impact on eyes.
Sure. I'm not sure we're, that in deep in the research studies in terms of screens yet. It's kind of just ergonomics and best practices and relaxing the eyes. So I don't believe there's a difference in type of screen. Really, what's important is your working distance, which is a term that is talking about how far away you are. So we want you around, it depends. Just basically don't hold things too close to you. So in that way, maybe having your laptop a little bit further or desktop computer a little bit further can be helpful in causing your eyes not to have to focus so hard. But yeah, I don't know of any correlation in terms of how big the screen is. When we talk about taking breaks, where, I said easier said than done. So theoretically, there's a practice called the 20-20-20 rule. So every 20 minutes of looking up close, you just take a quick 20-second break and look 20 feet away. So that is just a reminder to take breaks and relax your eyes. But I would say no specific concerns. It's just in terms of trying to have breaks and not work your eyes too hard during the day, especially if you're on computers for 8 hours.
What a great tip there, the 20-20-20. I hadn't heard that, so that's a good one for all of us, as many are looking at screens and even during this presentation itself. So a couple more questions here to wrap us up. The main difference between an ophthalmologist and an optometrist, obviously we have both represented here with our healthcare experts. So Dr. Lipsey, do you want to start in as an optometrist, your practice, and then Dr. Morrow in terms of an ophthalmologist?
Absolutely. So an optometrist goes to optometry school, which is different than medical school. So it's its own 4-year program, a little bit of systemic health, but then generally focusing on the eye for all 4 years. So that is the biggest difference is we have a different training program. For optometrists, a residency is optional. So I did perform an ocular disease residency for a year. So it's a lot shorter time period. And then the biggest difference is optometrists typically are not surgeons. So in the state of Iowa, we are not doing any laser procedures, any operating room surgeries, things of that nature.
So for ophthalmology, I went to medical school. And so then we do 4 years of medical school where we do just like same schooling as your primary care internal medicine doctor does, your orthopedic surgeon. We all do those 4 years. And then we specialize for residency afterwards. Ophthalmology residency is 4 years. So did 4 additional years in just specifically ophthalmology. And then kind of we do our eye surgeries and lasers and injections and eyelid procedures. And so that's kind of what kind of the big differences are, I think.
Okay. And any last thoughts either you'd like to share about the importance of annual exams and the frequency of it? Again, there's probably a few more questions that we may not be able to get to that people have some specifics. We would want to encourage them to be able to seek out one of our team members, but just overall in terms of annual exams, what would you say about that?
Go ahead.
It depends on your age and it depends on your eye history. Overall, if somebody is young in their 20s, 30s, they have no eye history, they don't wear glasses, don't wear contacts, once every couple of years is perfectly fine unless they're having issues. Other people who have eye history in those age ranges might need more frequent follow-up. As we get older, 50s, 60s, even above, yearly dilated eye exams are much more beneficial. Most of the diseases and everything we talked about today is associated with age. And so just making sure that you get those yearly dilated exams to make sure the inside of your eye is healthy is very important. And it's one of the only organs in the body that we can actually look into without cutting you open. So we dilate your eye, make sure everything's looking good. We can see a lot of systemic issues sometimes that you may have in your body, in your eye. So I think it's very important to get a yearly exam by an eye doctor.
The only thing I would add is more the younger ages. So yeah, we're not looking for conditions necessarily, but when someone had asked about the lazy eye, there are some things that are better found. Well, all things are better found early, but so for that reason, even if children are seeing well, we do want an exam, and then from then on, it can be determined if it needed to be yearly or not, but just making sure there's nothing at the baseline that needs to be addressed.
And Dr. Lipsey, I said we'd probably get this question, and we had it the very first question that came in. They were wanting to know if there's a relationship that you might have to an Iowa State basketball player. So I'll let you answer that.
Yes, so I did grow up in Ames, so that's my little brother. There's my parents, me, two sisters, and then Taman. So that's us.
Well, once again, thank you both for taking time today to share your expertise with our McFarland Clinic Eye Center. And thank you to all of our participants on the webinar today. A reminder that it is being recorded. We will be placing it out on our website. Those that registered for this webinar will get a link to that recording. And right here at the conclusion, we will offer a survey as well. We would ask that you take a few minutes there to provide your feedback and additional topics that you would like to learn from. So again, thank you all for attending today. Have a great day.